Great. First of all, thanks to Rupert and Sarah and all the many other people who helped in putting this together, and it's great to be here. Good morning or good afternoon wherever you are in the world. I'll first start, and I do have disclosures. I get funding from a nonprofit as well as some pharmaceutical companies for my research, and I'll just mention that. Yale has an institutional conflict of interest with esketamine. I do not. I don't get any royalties or anything like that for esketamine. But I'm delighted to talk about our experience in a line of research that we've been trying to develop at Yale for a number of years now. And it's embedded within our clinical treatment program at Yale Psychiatric Hospital. We started providing intravenous ketamine outside of research protocols as a clinical treatment. Now it's coming up on 7 years ago. And when the US FDA approved esketamine in 2019, we adopted that into our program. And since then, it's probably more like 400 or 500 patients that we've treated with either ketamine or esketamine, and have had a number of a cohort of them who have been receiving treatment for a number of years now. I want to start with a model that has guided a little bit of our thinking in this, and I think it dovetails nice with Adam's presentation about how do we treat people long term and minimize the exposure to this drug. So this is the model, and this is from a paper from a few years ago. And just as a caveat, my colleague reminds me, Chris Pittenger at Yale, that all models are wrong and some are useful. Certainly there are many nuances to treatment and such that a model doesn't necessarily pick up on. But here in the left frame, you might call a monomodal treatment approach, where more and more I think we're understanding mood disorders as well as a number of other psychiatric disorders as problems with the adaptability or the plasticity of the brain, and that many treatments, it's not specific to ketamine, but many treatments when applied during a depressive episode will enhance the plasticity of the brain and be associated with a reduction in symptoms and so forth. But inevitably, it seems like in many patients, when these treatments are withdrawn, at least for the most severe patients, there's kind of a return to the disease state and a return of symptoms and so forth. So, what we're trying to think about is moving to panel B, where at some point when the treatment, whatever it is has placed the brain in this period of enhanced kind of plasticity and adaptability, that we can kind of lock down any changes in a positive way, and that can hopefully lead to improved long-term outcomes. I guess one way you can think of this, if depending if you don't have a deep background in neuroscience, and I've tried to explain it to my kids or my wife this way, is that if you take cement, when it's wet, you can mold it, shape it, you can write in it, and when it hardens, it will continue to take that form. So this is kind of the high level principles that we've tried to use to guide our thinking. We are starting our third study that uses this kind of approach to try and improve long-term outcomes. I'll go through each one quickly. The first one, this was several years ago, and this is when ketamine was still fairly new. We had a protocol where we would give patients ketamine 4 times over 2 weeks, and we would intersperse with that cognitive behavioral therapy. So they would come in one day, get ketamine, and come in the next day, get CBT, come in the third day and get ketamine and CBT the day after that, and so forth. And this would be repeated over 2 weeks. So, our thinking is that we want to kind of intersperse the psychotherapy and the ketamine to try and take advantage of a window of enhanced plasticity the ketamine kind of induces, and that CBT tries to lock that down and lead to improved longer-term outcomes. The ketamine would stop after 2 weeks, and the CBT would continue. This is just what we call an open label, single group study. There's no randomization. Everyone who comes in gets the same protocol. We're just trying to learn a little bit, and we ran about 16 patients through this, and in this graph I'm classifying them as either responders or non-responders based on the first kind of 24-hour period after the first ketamine dose. And what you can see here, there are two different kind of measures of depression severity in the top panel and the bottom panel. The blue graph, the blue line are those who respond, and you can see that they more or less stay well for about 2 months following the ketamine treatment period. So the ketamine is in the shaded region on the left, and then that stops in about 2 months after that. Where for the most part, the people who responded initially, they kind of, what we think is soaked up the CBT and did fairly well. Those who didn't respond, they didn't really respond to CBT either over a 2 month period. We looked a little further out, and so this was very encouraging. And we looked a little further out and followed these people for a few more months, at least the responders. It was disappointing that eventually the 8 week mark here is where the last graph stopped. They would start to taper off and relapse. But when we compare this to kind of similar protocols, similar ketamine protocols that did not add some sort of CBT after, that's the green and the orange lines. That was from Mount Sinai in Minnesota, some folks there. It did look at least promising for the first 8 weeks while the patients were getting CBT. This was a very sick group of patients. They're coming for clinical treatment. About half of them had ECT in the past. I think 2/3 or 3/4 of them had a psychiatric hospitalization in their lives. So these were sick patients, and our thoughts, well, maybe the CBT is not long enough. Maybe we need to give some, as we call them, booster sessions. So I want to share with you what we maybe call version 2.0 that we finished not too long ago, and these results are under revision right now. But this is this involves a randomization aspect, and so what we did here is, instead of having the ketamine and the CBT overlap, we put them in sequence, and we really only randomized responders. So at this point, we're a little more comfortable giving 6 doses of ketamine. More data has come out, and so patients get ketamine 6 times over 3 weeks, twice a week, and if they respond, they are then randomized to the next phase of the study, either to CBT or treatment as usual. So this is the next generation study that we finished up a year or so ago. I'll share just a little bit about some of again, these are very small pilot studies at this point, so it's not definitive, but we ran almost 30 patients through this protocol. Half were, well, 30 patients that we got responders to. We got to respond to that course of ketamine. There was something like 50 that we initially put through here. And you look at these patients, and they're fairly sick. The median duration of the current episode is about 3 years. The most of them have been hospitalized at some point in their life. About a quarter of them, not quite a quarter, have had ECT, and half of them, qualify for what we call melancholic depression, and a number of the, they've on average tried about four adequate trials of antidepressant before they tried ketamine. So this is what it looked like, and so we followed these patients for a number of weeks, and the CBT protocol was more extensive, longer, and so forth. And what you can see here is, the ketamine, the shaded region on the left is that 3 week course of ketamine, and that stops, and patients continue either getting CBT or treatment as usual. And the patients getting CBT, they start to to diverge from those getting treatment as usual. This is a measure called the QIDS. It's a self-report measure. Again, this is a proof of concept study. It's not definitive, but this looked positive to us, and certainly enough to kind of merit further investigation into this type of treatment approach. It was we didn't quite see the same strength of signal with the clinician rated outcomes. This is called the MADRS. This was not significant, but see maybe a little bit of a hint of divergence towards the last month of treatment. We also wanted to kind of gauge, we're thinking that maybe these treatments can interact in a way that produces some sort of synergy. So we're trying to kind of measure what you might call cognitive flexibility, and we've been struggling with the best way to do this over the last several years. But what we used in this study, a subset of patients underwent testing with two kind of psychological measures that measure, you could say, measure flexibility. One is this NBAC task, where you were shown a series of cards one at a time for I think the card stays on your screen for maybe half a second, and you're asked to answer the question of whether this card is the same as the one you just saw or two cards ago. And that may not seem like a difficult task, but especially when you get to two back, you have to update in your memory, what is that card that I saw two cards ago? Is this the same one? And it keeps changing. It's a challenging task. And then the one on the right is this Stroop, where you see, words that spell out colors, but their font is in a different color, and you're asked to read, what the color actually is, the color of the font, or whether what the word actually says, and the timing of it is that's your performance outcome. So again, the hypothesis that ketamine enhances kind of cognitive control or flexibility, and then CBT locks it down. So again, we're still trying to get the best way to measure this. In a subsample of patients that did this, those who responded had a significantly different, kind of change in their accuracy on one of these tasks. This is the NBAC, and they improved at a greater rate than those who did not respond. So, those who, for whatever reason, their symptoms improve, they seem to have better cognitive flexibility or control after this. The Stroop, it was not, statistically significant. Again, these are small samples and there's a lot of variability. It was kind of trending in the right direction. These show the difference in reaction time before and after ketamine, and stratified by those who respond and those who don't. So what you want to see is a drop, a negative number that indicates improvement. So that's the high level results of our most recent study that finished a year or so ago. We were fortunate to get funding to do a slightly larger study. We're calling it the Endure study, and it's different in a couple important ways. One is that we're only recruiting, at least for the time, we're only recruiting inpatients. These are patients with depression and suicidal ideation who are in need of hospitalization. So highlighting the importance that Elizabeth talked about earlier this morning about doing research in real patients who have some risk of suicide. We're trying to recruit those who are at fairly high risk. All patients we are going to receive treatment with esketamine. Given this is funded by the NIH, the thinking was that esketamine would be more implementable. I think it hasn't quite worked out the way some people would have thought, but that's what we're going with for now. So everyone receives esketamine, and then patients are randomized to either CBT or treatment as usual. It's a single blind study. The raters are going to be blinded. Can't really rate blind patients to this. And the CBT is a combination of in-person and computer-based therapy. It's a program called Good Days Ahead, which has been used before in several funded studies in the past, and it's targeted to help address suicidal ideation. So this is a two-site study. It's slightly larger, about 60 to 70 patients, what we hope to recruit. Involves Yale and also Rick Shelton and Matt Macaluso from Alabama, Birmingham in the US. So This is a little bit about what the protocol looks like. Again, patients are in the hospital when they're recruited. They are randomized to esketamine plus CBT or kind of esketamine minus CBT. One of the other things here that's a little different, we're, I guess, compromising between our first two pilot studies, and we're overlapping the CBT and the esketamine somewhat, not completely, but there's a 2-week overlap phase between phase 1 and phase 2. And, we obviously hope to see rapid antidepressant effects and potentially anti-suicidal effects, but I think one of the key things we're looking for here is the long-term game. And so these patients are in the protocol for up to 6 months. So that's protocol. It got off the ground actually just this month. We recruited our first 3 patients this month. Excited to get that going, and it'll be a few years before we get some results about that. But as so many things in research go, this is obviously not just my effort, but I just want to thank so many people at Yale and also our collaborators at University of Alabama. Rick Shelton, Matt Macaluso will be coming on board in the next little bit. So these are all the people who've made this work possible, and I would be a little remiss if I didn't thank those who made it necessary. At least for me, that's my children. And with that, I'll answer any questions if there's a little time, or we may do that at the end. But thanks for your interest.